Welcome to Physician Focus. I'm Dr. Bruce Carlin. Diabetes is one of the country's most prevalent chronic conditions, affecting nearly 29 million Americans, or 9% of the population. Another 86 million are living with prediabetes, and nearly 90% of those are unaware of it. The disease is now the 7th leading cause of death in the United States and contributes to a variety of other serious conditions, such as heart disease, blindness, kidney disease, and amputations. This edition of our program will take a close look at this condition, examining such questions as why and how has diabetes become so prevalent? What can be done to reduce this epidemic? Can diabetes be prevented? And if so, how? And what are the latest treatments available for patients? With me for this discussion is Dr. Michael Thompson. Dr. Thompson is board certified in internal medicine with a subspecialty in endocrinology, diabetes, and metabolism, and is a physician and chief of adult diabetes clinical research at UMass Memorial Medical Center in Worcester. Welcome, Dr. Thompson.
Thank you, Bruce. It's a pleasure to be here with you.
It's nice to have you again. Tell me, how big a problem is diabetes?
Well, I think that, it would be shorting it to consider it anything other than an epidemic. It's now at close to 10% of Americans that have it. If you're over 65, 25%, that's a quarter of people over 65 have diabetes. That's just remarkable. 1 in 3 Americans with prediabetes due to risk factors for it. And, it's directly and proportionally linked to the increase in obesity in our country. And then it's a global epidemic too, which just means that it's a world problem. It's not just a U.S. problem.
Is this mostly from our diet then? Is this the underlying cause, that we're eating too much?
Yeah, I think it's pretty clear that it's related to the kind of foods we eat and the density of calories in our food, and I mean, it's a great thing that we have so much available, but it's also the burden of trying to eat healthy and to eat the right kinds of foods, that when there's stuff around that we enjoy, and we have lots of good foods and desserts and fast foods and things that people like eating, and it's just not healthy for us.
So the vendors that come in and bring you a bunch of scones and some coffee lattes and things like that. It's
all good stuff, and I try to avoid it.
And it's none of it is good for you, basically.
And you'd think that we have known this for a while, and that we've been promoting good health for a while, and you would hope that we're starting to see some change. I think that maybe the obesity rise has plateaued over the last few years, but the slope of those curves, when you look at it, is just amazing. How it becomes more and more and more prevalent, and the kids, really, the fact that our younger population are so affected by obesity and having more diabetes is really disturbing.
So the curves you're talking about is the curve for obesity.
Well, if you look
epidemic.
at over the years, if you look at for every year how many people have obesity and what percentage of our population have obesity going back for decades, and then you line up the increase in prevalence of in the number of people that have diabetes, they just match up completely. So I think it's clearly related to our weight and to the obesity epidemic, and that probably pays a lot into what we need to do something about it.
To correct it. So let's be clear, there are different kinds of diabetes.
Sure.
So that, why don't you review that with us, the type 1 and type 2?
I think that's important because it's while 90% of it's obesity related, there's definitely more than that. And so type 1 diabetes is a very different condition. It's a condition that has no insulin, and insulin is the hormone that controls blood glucose in our body. and you lose that insulin because your immune system attacks the cells in the pancreas that make insulin. So the pancreas is down a digestive gland in our body, but it happens to have within it these clusters of cells that make a very important hormone called insulin that helps the whole body to take glucose into its cells. If you knock those cells out, you have no insulin, you have diabetes, your blood sugar goes up, and all the consequences of it. Now that's a condition that that effect is very different than type 2 diabetes, but has a lot of the same side effects, a lot of the same damage to our body.
Same common pathway of destruction.
Of destruction, right. So the complications are the same, and so there's things about it that present the same, and we label it the same, but it's really a very different condition. That's type 1 diabetes.
And that's a very small portion of the diabetics.
Yeah, we often talk about it as 10%, but I think that it's less than that, really. And in fact, we think of that used to be called juvenile onset diabetes, and because it was really the type of diabetes more common in children. And there's a lot of type 2 diabetes now in kids because they're overweight. And then there are some family syndromes. So there are people that will not
diabetes.
fit the mold. There will be people that have a lot of diabetes in the family and they're not as heavy. But when we're really talking about type 2 diabetes in this big epidemic, we're talking about a condition that is a product of, I think I would agree with you, it's a product of our lifestyles and our diet.
So how do we break that down a little bit further? So in our discussions before the show, we were talking about prediabetes, and we were discussing that there's sort of before you blossom in diabetes, you've got prediabetes. How do I know I've got it, and what's that all about?
Right. So it's really, this whole thing is entirely a spectrum. You start by being overweight, you probably have risk factors and a predisposition, and then you move through a period where you might have a slight imbalance of blood sugar, and then you move on to diabetes. And I'll talk about the particular numbers, but in general you have to think of it as a continuum. So we create cutoffs because we know that at a certain point people have a high enough blood sugar that they're going to start to run these complications. So we know that by the time a person hits that threshold that we're going to diagnose diabetes, it's not like a switch went off and they just got a condition. It's that their levels are high enough that we start to see these complications in the eye, in the kidney, in the nerves, and the downstream effects of it. The prediabetes is in that zone between what we consider completely normal and diabetes. And we diagnose that with tests that can be done in the lab, but there are a lot of things that people really need to be knowing. There is, I think you said 86 million, right? People with prediabetes, 1 in 10. And really everybody, therefore, should look at the risk factors for prediabetes and judge where they fit in that spectrum and start to do something about it.
Well, certainly in my office, you come for your yearly physical, we check a sugar.
Right.
And anything over 100 now, I'm bringing you back and we'll check you again.
And that's a fasting blood sugar, right? So that means...
plus minus.
Well, true. So
it should be fasting, but it isn't always.
But for the diagnosis, right? So to get that person, I agree with you, by the way. I think if you're doing regular blood sugars and they're elevated, you got a problem. But between 100 and 126, fasting is that range that we call prediabetes, over 126 for a blood sugar. That's done in the lab. People would come in and have their blood drawn. It's not really done on the home meters for that.
Well, what I've got happening often in the office now is that patients don't feel right and they check their blood sugar in their friend's meter and they say, geez, it was 150 or something. And I say, yeah, come on in.
Exactly.
And that's not a bad way to...
I don't think it is either. I think that...
make the diagnosis.
I think that that knowing about it is what's important, and not, so feeling, people feeling free to take access to check their blood sugar on a friend's meter, as long as they're changing the lancet and doing it right, is fine by me too.
Do it cleanly.
And then now we've also, I don't know if you want to talk about the A1C test at this point, but I think it's a really valuable tool because we've spent a lot of effort to take the A1C and understand
Explain what the A1C is.
So hemoglobin A1C is a test. It's a blood test done on a blood draw from your arm in the lab. And it is it's a test that tells you how your blood sugar has been running on average for the previous few months. Usually we consider it 3 months. So it's going to take, if your blood sugar goes up after you eat, if it goes down, it's going to average all that out. And it's a test that changes slowly over time, so it becomes a reliable test. We've also looked to see exactly what a number means in terms of what is completely normal and what is high enough that it creates this diagnosis of diabetes.
So, but again, hearkening back to what you were saying, you're saying that we chose these levels because of the likelihood of complications of diabetes. So the same goes with the A1C test.
So we backtrack. We take the A1C and we know more about we know a lot about what the blood sugar level that will cause problems, and we know now pretty accurately what blood sugar level that will correlate to with an A1C. And so there's a range. So a normal A1C is a test result of 5.7 or less. And if you're between 5.7 and 6.5, you're in that pre-diabetes range. And the value of that in an office practice is that it's a relatively inexpensive test that you don't have to have somebody coming in fasting for to really make the diagnosis. Although I'm going to agree with you that a random blood sugar in the clinic is a valuable tool too.
But and you can use it. But if I'm hearing you correctly, you use it to say you got to change some habits here, buddy, because you're due for complications unless we get these sugars under control.
And the other reason I really think that the concept of knowing and people knowing the A1C test is not just an abstract thing that ought to be just your doctor worrying about it, because that's the measure that people know over time. If they have diabetes, they really should know what their score is. It's their best marker of how they're doing. Our goal for diabetes management is to have it below 7%. And I have people that have had years of diabetes who will come in and they can't tell me their A1C. It's a point of education for me. I really think that it's important to follow it if you have a problem. So it's a test worth having people understand.
So it helps your patients focus and take responsibility for their disease, and that's a main point of let's say patient citizenship.
Absolutely.
So. If you haven't tested on your friend's meter when you feel funky, how do I know that I've got diabetes? What are the signs and symptoms, and how do we make the other diagnoses?
Yeah, let's talk about two things. One is who's supposed to be worried about it and thinking about it, that pre-diabetes. Because if we start talking about the symptoms of diabetes, you already have a very high blood sugar. So symptoms of diabetes are if your blood sugar is high enough that you're starting to have excess urination, or you're losing weight from it, you're thirsty, getting up at night, you can't go through the night without having to get up to go to the bathroom. By that point, your blood sugar is over 200. We want to catch you before that. But those are the symptoms themselves of diabetes: blurry vision, irritability. I'd like to say we should have our audience focusing on if they don't, are they at risk? And those risk factors, those pre-diabetes risk factors, are having a family member, a first-degree family member, one of your siblings with diabetes or a parent with diabetes, being overweight. You know, you can, if you go on to do one of the, like the CDC pre-diabetes screening test, it gives you a score based on your risk factors, your weight, your family history, and your age, and depending on, and actually your activity levels. So if you're younger and sedentary, it's a risk factor. and then you get a score, and it's something I think people should be doing and bringing to their.
This is all in an attempt to get people before they have these complications, because once you've got the complications, you've been living with your diabetes way too long.
Absolutely. And I take care of diabetes. That's what I take care of in my practice. And I think there's a tremendous amount of need for education in talking about that. But I think it's a tip of the iceberg and it's clearly worth the effort to have people thinking about pre-diabetes and stopping it there.
And counseling people to start on their diets earlier than when they've got the diabetes and have to go on a diet.
Yeah, I think I think it's maybe not even surprising. I think a lot of people would know they were overweight and that they weren't doing so well. But I think getting to focus on it and to just deal with it, as opposed to putting it off to another day or to wishful thinking.
Let's talk about those patients that have migrated over onto, all right, you got the full-blown diabetes, you haven't taken care of it, you've ignored your meter, and now you've got complications. What are those complications?
Well, the classic diabetes complications are the blood sugar-related complications are damage to the blood vessels in the eye, so that it can cause bleeding in the eye and blindness. It damages the nerves, and the longest nerves, the nerves down to the feet, are the first affected, so that you can get numbness and tingling and burning discomfort in the feet, and that can lead to problems with sores that don't heal, and so that's why diabetes is a leading cause of amputations. And the kidney is very sensitive to high blood sugar, and will, if untreated for long enough time, you can damage the blood vessels in the kidney, and it doesn't function as a filter, and people go on to dialysis. But probably the biggest correlated condition that really kills the most people with diabetes is cardiovascular disease, heart disease. So and that is tied, that's more related to the weight and the cholesterol and the blood pressure issues that come with being overweight than necessarily it is to the high blood sugar. But that would be the spectrum of diseases that go hand in hand.
So we've got this epidemic. We're hopefully getting people to pay attention to their diets and to take some steps to correct it. It seems to me that there's a vast armamentarium these days on how we treat diabetes. Why don't you go over how we typically approach all of this?
Sure. And some of these therapies are quite useful early in treatment too. Some of them can be used to prevent progression and go on to diabetes too. So our first line therapy actually is a drug called metformin, which we've been using in the United States for a lot of years. I think it came here in 1985 and had been in Europe for longer than that. And metformin has stood the test of time as being a great drug for treating diabetes. It helps to settle down the metabolism, to keep the blood sugar down without promoting weight gain, which some of the other medications I'll talk about can do. And so metformin is a great drug. It's inexpensive, and it's a
first line drug.
And then we've had drugs that stimulate insulin release from the pancreas for a long time. And those drugs are called sulfonylureas or sulfa drugs, and they are useful, but they can cause low blood sugar and they can cause weight gain. And so there's always been an interest in looking for other drugs, maybe like metformin, that'll help to promote weight loss. And we are seeing just an explosion of different agents that are coming into the clinic. Some of them with very interesting ways of working, like these drugs, the GLP-1 type drugs in milder form by pill. And
GLP is just is doctor speak for some enzyme that does something.
Like intestinal peptide 1, but which hardly tells you what the drug is doing. But as a category, it tends to be an important regulator of our metabolism. When we eat, the food goes through our system, releases this hormone, and helps to tell us we're fed, helps to release insulin from the pancreas. It coordinates our metabolism, and we've been able to use that both in a actual hormone form that's injected or in pills that raise the level to get a lot of to gain some control with weight loss, which is an important thing, and without causing low blood sugars. So along the lines of metformin, and those are new drugs. And then
sort of increasing satiety at the same time?
They do, and so there's significant weight loss that you can see with some of these drugs. In fact, one of them is now indicated as a weight loss therapy, even without diabetes.
Which is, correct me if I'm wrong, but that's a whole new kind of thing. In previous eras, the weight loss drugs had significant bad side effects, so that this is really on a much better level, much more honed to the specific problem.
Yeah, I think that we are starting to use medications that are treating some of the underlying processes and more of the underlying disorder better. And then there's a brand new category of drugs that blocks the ability of the kidney to hold on to sugar. So you end up losing the reason that you have increased urination when your diabetes is out of control is that it flows out into the urine and draws water with it and causes this increased urination. Well, we can actually take and block that so that it happens at a lower level, and actually the sugar after you eat goes right out. Now that sounds like cheating to me. I don't know what you think. It seems like you can.
Oh, I can eat extra
sugar,
it
and it's gonna go right through you. And when I knew these were coming out, I thought that is the craziest idea. But in practice, they can be quite remarkable. They cause weight loss. They're well tolerated. And so they're not as controversial as they may at first sound, and there's a bunch of them out now, and so that's an interesting group. And then many people are going to need insulin, and we have insulin therapy nowadays there are more people with type 2 diabetes on insulin than type 1 just because of the numbers of people with type 2, and insulin is available in very convenient ways to dispense disposable pens that dial up and
you can actually read
and are easy to use, and the needles are tiny, and so insulin's we've had a lot of advancements in insulin therapy too.
And talk to me. They're talking now about inhaled insulin.
And there is, we had an inhaled insulin on the market for a few years back. Exubera, you may remember that was very complicated to administer. It had quite a large inhaler device, and you had to put the powder in it. And I think just basically because of the way it had to be delivered,
its clumsiness was
it just
too much.
Didn't make it. And this is a very nifty little device. It's a little plastic thing that you pop a capsule into, and you can take a puff, and it gives you insulin right into the lungs. And so it's brand new. I actually don't have a lot of folks that have used it yet, but it'll be interesting to see how that helps people. The idea being that it's so much more convenient than taking a shot. But as you pointed out, taking shots is pretty easy these days with these little tiny needles.
So what happens with the type 2 diabetic that are we curing anybody? Certainly with some of the obesity surgery, we've seen dramatic improvements in people's diabetes. Is that going to happen?
That the obesity surgery has had a lot of publicity as a cure for diabetes, and I think it just shows you that that dramatic weight loss is going to reverse this condition, and I think that's an important point. I think actually that's something that people with diabetes should understand, that with enough weight loss it can reverse. Many patients who go through obesity surgery, even if they've had diabetes for a long time, will revert to normal and not have diabetes anymore. And
as soon as they regain the weight, back comes the diabetes.
It is true, and it seems like a radical approach, but it is life-changing. And I never discourage a person that has really gotten to that point of morbid obesity, that it's disrupting their life and it's going to be hard for them to reverse that in a way that they can with obesity surgery. So if somebody has gotten to that point, and I support it completely, because it's life-changing for them in a lot of ways, not just in terms of reversing diabetes. It's good for their knees too.
Well, Dr. Michael Thompson, you have been a marvelous guest. Do you have some thoughts that you want to leave us with, important thoughts about diabetes?
Well, I mean, I think that for me, I think it's important to be positive and to have a good outlook towards taking care of yourself. I think that one of the things that disturbs me the most is if a person comes in and says to me, you know, I'm your worst diabetic, or I'm a bad diabetic, or it's my fault. I just find that negativity isn't helping them, and that that realistically it's a positive approach that I can do it that's going to make the job done. And I think that the key elements are to take action, and to be objective about your situation, and to accept if you need therapies, we're mostly asking people to live a healthy life. We're asking people to eat right, exercise, and those are all good things to be telling people to do.
Well, thank you. You've been a wonderful guest. Thank you very much, Dr. Michael Thompson. For more information on diabetes, as well as many other topics in medicine and healthcare, visit our website at physicianfocus.org. I'm Dr. Bruce Carlin. Thank you for watching.
Hello, I'm Dr. Michael Thompson. Diabetes is one of the country's most prevalent chronic conditions, affecting nearly 29 million Americans. The disease is the 7th leading cause of death in the United States and can lead to other serious conditions such as heart disease, blindness, kidney disease, and amputations. Another 86 million people, more than 1 in 3 Americans, are living with prediabetes, and nearly 90% of those are unaware of it. A person with prediabetes has a blood sugar level higher than normal, but not high enough for a diagnosis of diabetes, and without lifestyle changes to improve their health, such as maintaining a healthy weight and getting regular exercise, many patients with prediabetes will develop type 2 diabetes within 5 years. Check with your doctor to get screened and tested, and act today. For more information, visit the American Medical Association at preventdiabetesstat.org.
I'm Dr. Rob Friedman. Cancer is the 2nd leading cause of death in the United States, surpassed only by heart disease. It claims nearly 600,000 lives each year. This year alone, nearly 2 million new cases of cancer are projected to be diagnosed, nearly 38,000 in Massachusetts alone. Yet many of these could have been prevented. Healthy lifestyle choices, a good diet, physical activity, protection from the sun, and a tobacco-free life can dramatically reduce your risks for cancer. Vaccines are available to prevent cervical and liver cancers caused by infections from hepatitis and human papillomavirus. And screening can prevent breast, colorectal, and cervical cancers and detect many other types of cancers early when treatments are most effective. Talk with your doctor about the steps you can take to prevent and reduce your risks for cancer. To learn more, visit cancer.org.